Component separation techniques, CST, are advanced surgical procedures used in the repair of ventral hernias, particularly large or complex abdominal wall defects. These techniques involve the strategic division or mobilization of abdominal wall components to close the hernia defect and restore the integrity of the abdominal wall. CST is particularly valuable when primary closure is not feasible due to the size of the defect or the loss of domain. Below is a detailed explanation of the component separation techniques. 1. Anatomy of the abdominal wall. Understanding the anatomy of the abdominal wall is crucial for CST. The abdominal wall comprises three layers of muscles: external oblique, the outermost layer; internal oblique, the middle layer; transversus abdominis, the innermost layer. These muscles are interconnected by aponeurotic structures that form the rectus sheath, which houses the rectus abdominis muscles. 2. Types of component separation techniques. CST can be broadly categorized into anterior and posterior approaches. A. Anterior component separation technique. Developed by Oscar Ramirez in 1990, this approach involves releasing the external oblique muscle to allow medial mobilization of the abdominal wall. Steps. 1. Skin and subcutaneous dissection. The skin and subcutaneous tissues are elevated laterally to expose the external oblique fascia. 2. External oblique release. The external oblique aponeurosis is incised longitudinally, typically 1 to 2 centimeters lateral to the linea semilunaris. 3. Muscle mobilization. The external oblique muscle is separated from the internal oblique, allowing medial advancement of the rectus sheath. Advantages. Provides significant medial mobilization, often up to 10 centimeters per side. Ideal for large midline defects. Limitations. High risk of wound complications due to extensive skin dissection. May lead to denervation or ischemia of the overlying skin. B. Posterior component separation technique. Transversus abdominis release. Introduced as an alternative to reduce the complications associated with the anterior approach. This method involves releasing the transversus abdominis muscle. Steps. 1. Retrorectus dissection. The posterior rectus sheath is incised longitudinally near the linea alba to create a retrorectus plane. 2. Transversus abdominis release. The posterior layer of the rectus sheath and the transversus abdominis muscle are incised to access the preperitoneal or retroperitoneal space. 3. Medialization. The fascial components are mobilized medially to close the defect. Advantages. Avoids extensive skin dissection, reducing the risk of wound complications. Provides access to a large vascularized plane for mesh placement. Allows for closure of larger defects with reduced tension. Limitations. Technically demanding and requires a thorough understanding of retromuscular anatomy. 3. Hybrid techniques. In some cases, a combination of anterior and posterior techniques is employed to achieve optimal results. These approaches are tailored to the patient's specific anatomical and pathological characteristics. Role of mesh placement. Mesh reinforcement is often used in conjunction with CST to enhance the durability of the repair and reduce recurrence. Commonly used mesh placement techniques include onlay mesh, placed over the anterior rectus sheath; sublay mesh, placed in the retrorectus space; intraperitoneal mesh, placed within the peritoneal cavity, less preferred due to adhesion risks. 5. Indications for CST: large or recurrent ventral hernias, loss of domain cases, inability to achieve primary fascial closure. 6. Complications. Despite its benefits, CST is associated with potential complications: wound infections and seromas, more common with anterior CST; chronic pain or discomfort; hernia recurrence, though less frequent with proper technique and mesh reinforcement. 7. Advances in CST, minimally invasive component separation. Laparoscopic techniques reduce morbidity associated with open CST. Botulinum toxin, Botox adjunct. Preoperative injection of botulinum toxin into the lateral abdominal wall muscles helps achieve temporary muscle relaxation and facilitates closure. In conclusion, component separation techniques represent a versatile and effective approach for repairing complex ventral hernias. The choice of technique depends on the size of the defect, patient factors, and the surgeon's expertise. With proper planning and execution, CST offers excellent outcomes for challenging hernia repairs.